I'm Dr. Brian Madden, Medical Director for Palliative Care here at St. John's Health Center, and I'm here today to talk about a difficult subject, hopefully in the most comfortable way possible. That is, comfort care, or care of the actively dying patient. I hope that by the end of this talk, you'll have gained a better appreciation for what we do in comfort care, both ethically as well as clinically, because it is important to me that you have trust and confidence in the orders that we're asking you to carry out. I hope that we're able to stimulate dialogue amongst all of us to talk about how to best care for these patients. Now, when we talk about comfort care, it is really only one part of what we do in palliative care, although it's perhaps the best known. People consider us to be having black hoodies, but this is really a white lab coat. And our preference would of course be to provide full treatment for our patients, but sometimes that's not necessarily possible, and we consider not escalating care and choosing selective treatments with the goal still to try to see if we can achieve limited improvement. But in those situations where it appears the patient may die regardless of what we do, comfort care would be appropriate. And the most important point here is that when we do provide comfort care, it is still treatment. So just as there is supposed to be comfort in full treatment, we want there to be treatment in comfort care. But occasionally with our patients, we know where this is going. And so these are the patients for whom comfort care is appropriate. So here's my own formal definition of comfort care. It's treatment provided to a patient for whom life-sustaining medical treatment would, in their autonomous opinion or that of their surrogate, it would do them harm and or provide them no benefit, no good, and therefore for whom withdrawal or withholding of treatment and symptom management or provision of medications would reasonably and understandably be expected to result in a peaceful death. So how do we justify this ethically? There are 4 principles of ethics, as you see here. And really, I think comfort care revolves around the first 3. Autonomy, which we all know is the patient or a surrogate acting in the best interest of the patient, being able to receive informed consent to fully understand the nature of the treatments or the nature of the withdrawal or withholding of treatments would do, so that they can make their choice of what is in their best interests. The second point is non-maleficence, which I want you to all practice saying that word, non-maleficence, better known as do no harm, where physicians, of course, are not supposed to be hurting our patients. Third point is beneficence, where we have a duty to actually do some good for patients. And then there is justice, and the only comment I'll make about justice is that it's not something that we want to be choosing on the individual case-by-case level. Justice has to do with distribution, use of resources, medical resources, and it wouldn't be appropriate for us to be making those judgments on a case in front of us. That's more of a societal issue. So how does this work with comfort care? Well, usually in comfort care, always in comfort care, we have the situation where the patient is already receiving significant medical treatment that is sustaining their life. They're already artificially supported. And then the patient feels that that burden of treatment, or their surrogate may feel that that burden of treatment is no longer providing them any benefit. They're stuck, they're going to get worse, and that burden of treatment they're receiving is actually uncomfortable. Perhaps they have symptoms, the symptoms are going to get worse, and therefore they're able to make an autonomous choice to change the goals of care from trying to either stay alive or improve to a peaceful passing. So once we've made the decision to proceed into comfort care, how do we do that? Well, there are 2 components. There's withholding and withdrawing, as I've alluded to. When we talk about withholding care, as I say here, it's easiest when the thing that you're going to withhold is something extremely invasive or harmful. Classic example of that is intubation. It may be very uncomfortable, or cardiopulmonary resuscitation, where we could potentially crack the ribs, we could cause a lot of distress without the potential benefit of doing any good. On the other hand, we have withdrawing treatment. Intubation, also a classic example, where it's quite difficult sometimes emotionally, especially for families, to consider withdrawing care because it may directly lead to the patient's passing. So, while they are emotionally different, legally they are the same. Ethically, they can be and should be the same, provided the reasons you're doing it are ethically valid. So, the other part of our definition, aside from withholding and withdrawing care, is that we provide symptom management. And this is where many of you have heard of Thomas Aquinas credited with the principle of double effect, where it is permissible for us to provide symptom management with the knowledge that the medicines we may be giving could lead to a bad outcome, in this case hastening death potentially. But as long as our intention is good to relieve symptoms, then it is considered ethically, morally, and within the Catholic religious doctrine, permissible. But this brings me to the question that everybody brings up, is if I do give morphine to a dying patient, am I killing them? And what's the difference between doing comfort care and assisted suicide, particularly with the new law coming out in California? And as I point out here, it's about your intention. When we give drugs to help somebody relieve their breathing or relieve pain, our intention is to relieve their shortness of breath or relieve their pain. Our intention is not to stop their heart. So it's an incredibly important distinction. The other point I want to make about it, and I'm going in the next few slides to illustrate it rather dramatically, is that if we were trying to hurt somebody, this wouldn't be the best drug to use. And this was illustrated last year, or 2 years ago, in a case in Arizona where they actually tried to kill somebody with morphine. In this case, it was Dilaudid. And they used 15 doses, and here are the sheets from the nurses recording it. You can't necessarily see it very well, but they gave 750 milligrams of both Dilaudid and Versed in under 2 hours. They were giving doses here, 14-13, 14-16, 14-24, just pushing until the patient passed. Now, we don't give anywhere near this dose. It just goes to show that it's not a really good drug. And this has been shown in our studies. When it comes to respiratory depression with opiates, the biggest risk are in patients who are completely naive to opiates. If we gave 750 milligrams to somebody who'd never seen it, yes, their breathing rate would be suppressed and they would most likely die. However, in the patients that we're often dealing with in palliative care, they have symptoms, they have pain. In fact, in the studies, it shows that there's no evidence for respiratory depression in opiate-tolerant patients who are symptomatic, given the appropriate amount of medication to relieve their symptoms. And most importantly, it really doesn't show that giving opiates hastens death. If the patient is not otherwise supported by medical treatment, the opioids alone are not going to be sufficient. You have to withdraw or withhold treatments, and disease needs to progress in order to cause death. So for that reason, I want to go over in some detail what we have here, and you'll often see our titration protocol. We mentioned first that we're supposed to use boluses as needed for breakthrough pain. If you have a patient, let's say, on 6 or 8 milligrams an hour, it's quite safe to give them an extra 2 milligram, 4 milligram bolus dose while you're figuring out, do they need this ongoing, or should I just give it one time and relieve their symptoms? As you can see, you can go up by a quarter, by half, by 100%. Now, if somebody's on 32 milligrams an hour, I wouldn't recommend going to 64, I mean, we can go up maybe by 25% in that case, but maybe do it every 30 minutes and push them up if needed to make sure that you're relieving their symptoms. But if they're on 2 milligrams and you want to go to 4, that might be reasonable. Point is that you're going to be looking to keep the patient calm. And we'll talk in a few minutes about what it looks like when a patient is dying. But ultimately, the signs you're looking for are quite clearly listed here. Heart rate elevated, grimacing, frowning, agitated, restless, moaning. If they can't otherwise tell you, I'm in pain, I'm short of breath, please give me something. Or give you a score for that matter. So some of the other treatments that you might see us order. We have our benzodiazepines, Ativan, Versed, Valium. We usually use those for anxiety, sometimes for shortness of breath, but they're really better for the anxiety of shortness of breath more than they're better for shortness of breath itself. Morphine is clearly the drug of choice for shortness of breath. But benzos can also be used for nausea, and they can be used in patients for whom sedation is desired. If in an awake state, particularly if they're nauseous and in pain, keeping them sedated may be the best choice and the necessary thing to do to keep them comfortable. In rare cases for patients who may seize and they otherwise have no access, where we could use Keppra, we sometimes will also use Valium suppositories for seizures or Ativan ongoing for seizure prophylaxis. You also may be familiar with our antisecretory agents such as Robenal, atropine, and scopolamine. The important aspect of these to know is that Robenal does not cross the blood-brain barrier and therefore is better to use in an awake patient and is usually our first-line treatment, whereas atropine can be given more frequently, usually in the mouth under the tongue. It's an ophthalmologic solution that we use for this purpose. But in an awake patient, you have to be very careful that it can cause delirium and to avoid using it in those situations. The other comment to be made about the antisecretory, they are anticholinergics and they will cause a rise in the heart rate. Then we get to our anti-nausea medicines, often a symptom that is very challenging to treat, and we have many choices for that with our Compazine, Zofran, Reglan, even steroids, Decadron, Haldol, Benadryl, to use for them. It also becomes very important sometimes that these drugs can be sedating, to be giving them on a scheduled basis if necessary so as to avoid allowing the nausea to return. I mentioned oral care here is also a very important thing because there was a study done that showed that patients for whom you keep the mouth moist who are unable to eat actually report less thirst and less hunger. It was a study of stroke patients where they were expected to recover, and they were actually able to show that about 85–90% of them reported that they did not feel hunger or thirst, but those were because of good oral mouth care. So I always emphasize that. It's also something you can teach the families to do so they can feel like they're able to do something for the patient. And then we talk about oxygen. Oxygen is one of those things where it probably doesn't make a huge difference in their breathlessness, particularly if they're unconscious or comatose. However, it's something you can certainly do, 2 to 6 liters nasal cannula so as not to be invasive. We do prefer not to use face mask for the reason of its discomfort. Foley catheter is desired because oftentimes it makes it easier. You don't have to move the patient as much. You don't have to change the sheets. However, if the patient is awake, they may refuse that. Bowel regimen, same story. Usually our patients on comfort care are not eating. They don't typically need to have a bowel regimen, but you should be aware of the potential for constipation, particularly with the opiates, and definitely in an awake patient, they need to be on a bowel regimen if they're going to be on opiates. And then we mentioned the spiritual support and comfort care folder. All patients who get placed on Comfort Care should be given the Comfort Care folder that we'll have available to show you. And when we put the orders in, we do ask for spiritual care. It never hurts to be redundant and to reiterate that and ask families if they would like the chaplain or priest to come by. So let's talk about what it looks like when a patient is dying. One of my references talks about this idea of the usual path versus the difficult path. And I think many of us, if you've had enough of these patients, have seen both happen. The usual path is a patient gets tired, they get more and more sleepy, they fall asleep, they're very comfortable looking, they become semi-comatose, moaning, maybe responding very little, and then fully comatose, and then they pass. But there is a difficult path that some patients will take where they start out being kind of confused, and they might get tremulous, a bit agitated, start hallucinating, go into a delirium, sometimes start twitching or having myoclonic jerks. At worst, that can lead to seizures before they finally settle down and become semi-comatose, comatose, and pass. So obviously it's our hope that through our treatments in Comfort Care, we can avoid the difficult path and give everybody the usual, or we could say easy path. But when a patient is starting to get to the point of what we would call the pre-active phase of dying, they may become almost universally fatigued, weak. They don't move around in bed as much. When you try to talk to them, they lose attention very easily, they fade out, they may be disoriented, say confusing things, have that change in their mental status. If they are eating, they may decrease their intake, not be as hungry, usually just sips of water to keep their mouth moist, as we talked about before. You'll see decreasing urine, stool. But the other thing to mention is that in this phase, sometimes they'll rally. And I think we've all seen it where you think the patient is heading towards sleeping, and all of a sudden they want to sit up, they want to talk, they seem like they're suddenly getting better. Again, if it continues, as I always say, it's easy if people get better, but it shouldn't be something that we should count on because it is often the rally before the final terminal decline. So we do have signs that show up when the patient is reaching what we call the actively dying phase. The most well-known of these is the death rattle, and that is an upper airway congestion that is best treated with the anti-secretory agents atropine, robenol, and it should not be considered true shortness of breath. It is, however, very disconcerting for families to see that, although we don't really have any evidence that it bothers the patient. The one comment to be made about it is not to use suction. We tend to avoid it because we feel that suction can overstimulate and cause more secretions and potentially be traumatic to the patient. In addition, we always check the radial pulse because that gives us an idea of what the blood pressure is if it's particularly low, because you'll lose a radial pulse at about a blood pressure of 80 or 90. And it's been validated as a measure of patients' impending demise, or a sign of their impending demise. In addition, we talk about breathing patterns. Now, of these, perhaps the best known one is the Cheyne-Stokes breathing, which is actually where the patient starts breathing faster, then breathes slower, has periods of apnea, and then resumes that pattern of breathing faster and slower. The perhaps more common is where you just see an open mouth and the jaw moves, and that kind of looks like where as they breathe in, the jaw kind of pulls back a bit. That is also actually a sign of active dying. And then the other signs we typically see, decreased urine output, loss of pupillary reflexes, And then this idea of the inability to close the eyes fully. That does not mean that their eyes are open. What it means is that they can actually lose fat behind the eye, and as a result, their eye can't close completely, and they're left with this bottom part of their eye that remains open. In those cases, using the artificial tears is very important to keep the eyes moist. But all of these signs together indicate that a patient may be passing within a few days. None of them have been validated to tell us exactly the amount of time the patient will continue to survive, but they are markers of impending demise. And the other comment to be made is that not all patients will show all of these signs, or even any of them at times. So then once the patient does pass, what do? The first thing to do is notify the doctors. If family is not present, notify the family or ask the doctor to notify the family. And the bereavement resources are in the Comfort Care folder. Things, organizations such as Our House, which is an excellent bereavement counseling, grief counseling organization. But if you have a situation where families are extraordinarily upset, grieving, crying, more dramatic, please don't hesitate to call spiritual support and/or social worker, even off hours, because this is one of the situations that they will come and help out with. And then we always ask you, and we try to prepare ahead of time to ask the family how they're going to want to proceed once the patient does pass. Many families like to stay in the room for a little while. If they have specific death rituals, they may wish to perform those. Some mortuaries, Orthodox Jewish mortuaries in particular, will pick the patient up from the room, and they need to be notified right away. You will know that ahead of time, though. It's not something where you necessarily have to worry about it, because otherwise the typical pattern is that the patient, once the family is okay and ready, they'll bring the patient down to the morgue in the basement, and then the mortuary will be notified, and they will come pick the patient up from the morgue. So what are the issues that come up? And I think this is where I'd like to spend the remainder of this talk. The most common one we always hear is, can't you speed it up? And this can come from families, but it can also come from the physicians. They're going to die anyway. Just give them a little bit more morphine. Just can't you make this faster? And this is where we have to go back to intention. If we have something that we're treating, it's entirely appropriate to raise the medication. But if the patient is just lying there comfortably, it's not up to us to try to hasten this any more than we need to relieve symptoms. So you go back to the question of assisted suicide versus comfort care. It's all about the intention. The other part of it is that it's just sometimes some people just don't feel comfortable doing this. And I respect that. As much as our patients have autonomy, we as caregivers have autonomy. And if this is not something that you want to do or feel comfortable doing, there's no reason, at least in my opinion, that you should be forced to do it. Sometimes it's because the emotions of the family also are just too much. I think in those situations, getting extra people to help, getting our social work, getting our spiritual support involved is very important. Again, sometimes you feel like the patient is receiving too much medication and they're too obtunded. Sometimes you feel like they're not receiving enough and they're suffering. I would say in the case if you're feeling like they're getting too much medication, I truly invite you to ask me why I'm doing what I'm doing if I happen to be the one managing it, because usually there is a reason that we've gotten to that point of medication and we feel it's important, but I would be very happy to hear why you might feel that way if indeed you feel like we're over-medicating the patient. But that also, the not enough medication also gets to those cases where you see a patient who seems to be symptomatic and you think this patient needs comfort care. And I think there it's always tricky because the goal, as we said in the very beginning, sometimes the goal is to try to give a patient a chance and see if limited improvement is possible. And if we do switch to comfort care, we may be hastening, or otherwise we may have a black and white situation where in order, let's say, we have to have the patient breathing a little bit faster, because if we suppress their breathing, their carbon dioxide is going to rise and they're going to be in a vicious cycle and they're going to pass. So I always say in these situations, again, treatment should not be uncomfortable, but sometimes you have to understand what the goals are and make sure that everybody's on balancing the goals of care, realistic goals of care, with appropriate symptom management while you're trying to achieve those goals of care. And in complicated situations, that's why palliative is often called, to help figure out what the ideal balance would be and help patients decide, or families decide, what's in their patient's best interest and what kind of quality of life they're looking at achieving. So this goes back to what we're really, the biggest picture here. I mean, we all work for Providence, and I really like Providence's vision statement, which is that we try to really understand our patients. We try to know them, we try to care for them, and that comment of ease my way. I mean, when it's time and the expected outcome is death, we want to make it easy. And I think amongst ourselves, I also say we want to make it easy for all of the team members to be able to do this. This isn't the kind of thing where I want you to feel like you're being forced or you're doing something that, I don't really, it needs to be that you can want to do this for this patient, that you understand why you're doing it, so that it really does become an opportunity to give the patient the same quality of care that we would give them if they were having a heart attack and we were trying to save their life, even though we're actually helping them end their life. Because we are not ending their life. Their disease is ending their life. We're just making it easy. And I think if we go back to our kind of values, it's not just what we do for the patients, but it's also how we treat each other with that respect, with compassion, being fair, of course trying to be excellent, and then trying to keep getting better. So with that said, and I turn it over to my colleagues and to all of you to kind of talk about this a little bit more, and some areas that you might consider is how do we make this an even better environment for our patients? Caritas in general, that particular unit where we have nice rooms and it's very comfortable, how can we make it even more comfortable? I'd also encourage you to share when you've seen it not done well. Why did it make you uncomfortable when it did? And what could we do in the future to avoid or to do it better in the future? And then also, like I've been emphasizing throughout this talk, I want you to feel open to be able to ask me if you see a patient on comfort care and you're not sure about what's going on, how can we improve the communication amongst the team, amongst physicians? And, be honest, I am working on helping physicians clarify goals of care that are realistic, and sometimes it's on us because we're not being realistic or we have our own issues around it. But I think that if we're all looking at it in the same way and we're all trying to achieve the same comfort to comfort care, we can make it work. So thank you all for watching. I really am honored to be able to talk to you all, and thanks again.